Hi, I'm Lucy Davis, and this is Room for Improvement, the podcast dedicated to service improvement in axial SpA care. I'm delighted to say that this is a one-off special on Axial SpA and IBD, and my season one co-host, Professor Hasan Tahir, is back with me today. Hi, Hasan.
Hey, hi, Lucy. Great to be back for today's episode, where we'll be talking to our guests about their experiences and taking a deep dive into strategies and techniques they use to push towards success.
We're really hoping that today's podcast is going to help clinicians and the wider clinical teams in rheumatology and gastroenterology to help drive down diagnostic delay for axial SpA patients.
Absolutely. We know that many people with axial SpA have inflammatory bowel disease, like Crohn's or ulcerative colitis. So today, we're delighted to be joined by Dr. Christian Selinger, consultant gastroenterologist at Leeds Teaching Hospital, NHS Trust, and also the IBD lead at the British Society of Gastroenterology.
And our other fabulous guest is Professor Raj Sengupta, who is a consultant rheumatologist at the Royal National Hospital for Rheumatic Diseases, Royal United Hospitals Bath, and a key clinical advisor to the Act on Axial SpA campaign. Christian and Raj have been working together to raise awareness and knowledge for gastroenterologists, and we're delighted that you're here with us today.
Yeah, thanks very much for inviting me. So I think as a rheumatologist who deals with axial spondyloarthritis patients, we know that the extramusculoskeletal manifestations are obviously really important. And we've always tried over the years to work with our dermatology colleagues, our gastroenterology colleagues, and our ophthalmology colleagues. But sometimes with the pressures of work, trying to create those links and facilitate a smooth transition for patients between each department can be challenging. So this work that NASA now are putting in place, I think, is instrumental in terms of reducing the delay to diagnosis. From an axial spondyloarthritis point of view, probably about 10 to 15 patients will have concomitant inflammatory bowel disease. And certainly when patients report symptoms like loose stools, mucus, blood in the stool, we will think about inflammatory bowel disease being present, and we might do tests like fecal calprotectin and think about referral over to the gastroenterologist. But on the other side, building on that data a little bit more, for example, at the Royal United Hospital, we gave 100 IBD patients the NAS inflammatory back pain questionnaire. And what we found is around 16% of those patients met inflammatory back pain criteria and would then be suitable for assessment by us in that context. There was another study from Walter Maximovich, and again, in this study, they looked at uveitis, psoriasis, and IBD, and in that cohort found nearly 50% of people who would have been diagnosed with axial SpA. So it's a hidden thing. It's a burden for patients who are not diagnosed. These are patients who really should be diagnosed, and I think work like this will help us get there.
Right, yeah, that prevalence is massive, isn't it? And Christian, how about you? Any sort of overview from the gastroenterology perspective on the problem?
So yeah, I think what Raj says is quite important. I think in dealing in the field of immune-mediated inflammatory diseases, they manifest mainly in one organ system when they present to you, but in very many patients, they're also present in other organ systems. And yes, skin, eyes, joints, these are quite common one. In IBD, we also got some patients with liver problems associated and so on. So when we come across those patients, in our ideal world, we pick up all those aspects. Obviously, we often focus on the immediate problem when somebody has got a flare of their colitis, for example, with a lot of bleeding, a lot of diarrhea, a lot of pain. That's kind of where the immediate focus goes. But it's really important not to forget the other bits. And some of our patients clearly are quite vocal about other problems, and they'll make us recognize that there might be an issue, but others can be quite quiet about it. And unless we ask directly, they don't make the link that could be related. So I think, appropriate referral of the right patients is really key to the earlier diagnosis. And there are, and we're going to get into that detail later, some ways now in more modern working, more digital ways of working, where we can possibly screen a lot more questions without actually asking the patient physically in that clinic space, but getting that done beforehand also. So it's a tricky bit to get all the important bits into a clinical conversation, but if we move away from the 1990s to 2024, where we are, we can maybe do things a little bit smarter and facilitate those important steps.
For the purposes of our audience, can you just tell us a bit more about IBD? Tell us what actually IBD is and how is it actually linked to axial SpA?
So inflammatory bowel disease is basically chronic inflammatory diseases of the intestine. The two main forms are ulcerative colitis, which affects the rectum and the colon only, and is mainly a mucosal disease, and Crohn's disease, which can affect anywhere in the GI tract as a transmural disease, can also lead to things like abscesses and strictures and fistulas and things like that. And they affect about 500,000 people in the UK. And as with other immune-mediated inflammatory diseases, they're partially genetically driven, partially with environmental factors, although we don't really understand them too well in all fairness. And there is a massive overlap in some of the genes that drive inflammatory bowel disease and that drive inflammatory arthritis, for example, but there's also quite a lot of differences there. And our patients present with anything from abdominal pain, diarrhea, bleeding, anemia, failure to grow, fatigue, and a variety of symptoms. And not every patient presents the same way. I think it's really important for us when our patients first get diagnosed that we do a little bit of a scout around and see what else is going on in their life and whether they actually tell you what. It's not my main problem, but I've got this back pain that's been there since I was 15 or so, and now I've got this colitis, and pick those two things up and so on.
So how is that? Okay, that's a really nice little overview of IBD, and how is that linked to, for us as a rheumatologist, axial SpA from your perspective?
So I think it's interesting to hear Raj say extramusculoskeletal manifestations, whereas in IBD we call them extraintestinal manifestation, which probably just highlights that on both sides we're kind of talking about the same multi-system disease. Yet some of my colleagues actually postulate that it basically is a multi-system disease that in some patients manifests in another organ more prominently than in the organ in a different patient. And I think probably we're talking about a spectrum of diseases there. We also at the moment label Crohn's disease as one and ulcerative colitis as one, and don't really look at all the different subtypes, and they're not clever enough in our ways of categorizing them to actually figure out really what the phenotype is and how that relates to other patients. And I think there's a great overlap. But there's also vast differences. And I think if we touch on treatment later, there are some treatments that work for both really well. And then other treatments where either I get really unhappy or Raj will get really unhappy if we propose them in our patients, vice versa, because they may actually exacerbate the other condition. So I think it's really important that when you have somebody where you consider they might have axial spondyloarthritis, that you do consider which treatments may affect actually both positively and not either have no effect on the other organ system or worse, actually exacerbate the other organ system.
So Christian, Raj mentioned earlier that I think approximately 10% or so of patients with axial spondyloarthritis may have colitis, be it ulcerative colitis and Crohn's. So as a rheumatologist, what do I need to do in my clinic to pick those patients up with colitis, for example? I'm doing it the other way around now.
Yeah, I think the tricky thing the other way around for you is that there are actually quite a lot of patients who've got irritable bowel syndrome. That's incredibly common. If depending on how you define it, somewhere between 10 and 25% of the population. So in all fairness, if you meet somebody in your clinic who's got some GI symptoms, the chance that they've got IBS is higher than they've got IBD. Yet it really matters a lot if they've got IBD, and we need to get that right, and vice versa. So I think in terms of symptom burden, whatever is important is alarm symptoms. So when there is weight loss associated, when there is inflammation that you can find with a CRP that you cannot explain by the joints, for example, that would be something in combination with GI symptoms that should get alarm bells ringing. When there is nocturnal diarrhea, very few of our functional patients actually get up in the middle of the night to go to the toilet, whereas when you've got true inflammatory bowel disease, that can happen. When there's rectal bleeding ongoing and so on. And the one thing that's quite helpful is fecal calprotectin, which is an intestinal inflammation marker. It's an inflammation marker, not necessarily an IBD marker. So if you have nasty gastroenteritis flare, it will go up as well. But if it's a chronic situation and you use it and it comes back negative, it does make the chance of having IBD quite unlikely. So if you have a patient, you're not quite sure, they don't show any of the alarm symptoms, getting them to do a fecal calprotectin. If it comes back raised, ask gastroenterology to involve themselves. If it doesn't come back raised, I think you can reassure the patient's probably not related to the inflammatory diseases.
Christian, can I pick on that point? So, as a rheumatologist, if I identified a brand new patient with axial spondyloarthritis, should we routinely do a fecal calprotectin?
Very good question. I think that requires a research study. The problem with fecal calprotectin, like with many screening markers, is that's fairly non-specific. And the question of whether we should investigate every new patient with axial spondyloarthritis for IBD or not, I think it needs to be properly investigated, because with all the stuff we can also do some harm, especially a colonoscopy. It's rare to cause harm, but 1 in 1,000 do end up in harm. So if we start doing it relatively unselected, probably a bit tricky, but I think it would be a good thing to investigate that further.
So, Raj, do you want to say something about that?
Yeah, no, thanks, Hasan. I just wanted to pick up on a couple of things Christian said, which really interests me as well. What are your thoughts around serum calprotectin as a marker? And secondly, with fecal calpro, is it 2 weeks that they need to be off anti-inflammatories before you measure it ideally?
So I'm not aware of an exact time frame to answer your second question first, that you have to be on it, but certainly being on an NSAID can be enough to cause inflammation. There's also some patients who've got sky-high fecal calprotectins, and we investigate them with every test we got, and we never find any inflammation in the GI tract. So it doesn't necessarily equate to a diagnosis, and that's important when you see a patient in the clinic to tell them this means you need to be investigated further, not you have a condition. We've never used routinely outside any research studies serum calprotectin. So I'm not sure whether it actually would be discriminatory. My understanding of calprotectin is that it's a degradation product of neutrophils, and hence when you have it in feces, it's relatively specific, although it's still fairly non-specific. But that the problem we've got with any serum markers, if you look, for example, take CRP, in some of our severe patients, it doesn't even go up. And obviously, if it goes up for another reason, it really doesn't point to the organ system. That's the problem.
I mean, for me, just going back to the whole point of IBD in our patients, the question I pose is, do they have IBS or do they have IBD? And for us, that's important when we choose treatments as well. Do you want to comment on that, Christian or Raj?
I think that's vitally important, especially, and I'll say it now, secukinumab is great for the spine. It's not great for the bowel. It doesn't so matter so much if there's no high risk factors or so. So I think if you choose such a treatment, it's worthwhile asking the question about GI symptoms, and if there's any doubt, at least get a fecal calprotectin off. Because if you have a treatment-naive patient, so you got lots of choices, then why not use something where you're not concerned about it? And vice versa. For example, the drug that my rheumatology colleagues are not very keen on is vedolizumab. And if I had somebody where I think like, oh, maybe not sure about their spine, I don't think I should use it as a first-line treatment when I've got 3-4 alternatives that I could use instead where it's not a concern.
Yeah, and the other thing to add is etanercept as well, that we tend to use as well. So we probably want to avoid that.
Yeah, so we do find a few people who are diagnosed while on etanercept and with their IBD. And yeah, we're quite keen that they switch to adalimumab, golimumab, or infliximab then we have a treatment that covers both areas effectively, rather than at best doing nothing for their IBD with etanercept. I'm not sure how strong the data is that it does harm either, but it certainly doesn't do anything positive.
It's so interesting, and I was really taken by what you were describing earlier, Christine, and actually that view from both sides. It's sort of the same thing, and how do we see it from different clinical specialties? So, Raj, I'd be really interested to hear from you sort of on the flip side. What do you think that gastroenterologists need to, and sort of the wider multidisciplinary team that they work with, of course, need to look out for in IBD patients that might suggest axial SpA or inflammatory arthritis?
Yeah, no, thanks, Lucy. And I think this is where really challenges around time in clinic become the issue, because we all in our own specialties probably get about 15 minutes with each patient, and we have quite a lot to cover in our own specialty areas. As Christian said, they've got a lot to do in terms of inflammatory bowel disease, assessing symptoms, examining the patient, reviewing investigations, coming up with treatment plans. So to throw in a series or a complex of things that we as rheumatologists would want gastroenterologists to ask, examine, and test for has to be practical. So I think you could take most of that out in terms of what advice I'd give, and probably even just start with a simple question of, do you have back pain, and has your back pain gone on for more than 3 months? And I think most gastroenterologists should have time to ask that. So I'll frame that. In my rheumatology clinics, I would ask patients about uveitis, psoriasis, Crohn's disease, ulcerative colitis, and ask them how active those things might be. And it's simply around that I think framing the situation for gastroenterologists would be important. So if a gastroenterologist can say to a patient, do you have back pain that's gone on over 3 months? If people are interested, they might even say, look, you're 60 now. Did you have back pain in your 20s and 30s? Again, for the super interested gastroenterologist, they might even say, has anyone said to you you've had sciatica in your 20s and 30s? Because often these patients have been incorrectly labeled as having sciatica all those years ago. And then finally, I think I'd probably say that if a gastroenterologist has asked and there's been back pain there a long time, the NAS symptom checker is superb, and just pointing that patient to the website to fill that in will definitely start the right ball rolling.
Raj, can I actually ask a question? I mean, that's great. So asking all those questions, we need to probably educate our gastroenterologists. Over and above that, how about have you, or actually Christian, has there been any work done on having questions or posters out in clinics for patients to look at and say, look, do you have back pain? If you have back pain, have a conversation with your gastroenterologist. Has that work been done by anyone, or have you thought of doing something like that?
So I'll just start and then Christian take over. So we haven't put posters up in our departments, other departments as yet. Again, going back to NAS have got some brilliant posters, by the way, that we could put up in our gastroenterology, dermatology, and ophthalmology clinics. I think partly it has to come with consultations with the specialty clinicians, because, and Christian, I'm sure will attest to this, if I go and put posters up, those patients will be going in and asking questions of those healthcare professionals. And there are two aspects there. One is, does that healthcare professional have the time to go into the patient's concern in any detail? And secondly, different people have different levels of knowledge around, say, axial SpA or uveitis. Do they really want to go into those things? So I think with that, maybe Christian, would you like to come in with some comments?
So I think in terms of asking, where I see the biggest gain in the future is preclinical questionnaires that increasingly are either being sent by electronic patient apps that trusts use to manage their outpatient information and appointments and so on, or even a paper questionnaire in clinic beforehand. Those can be quite helpful, and there can be really asking a lot of questions, and when there's a no tick spot, you don't need to spend any time on that with that patient and can move on to what they're really interested in. I think posters are a little bit tricky. For example, where we work in Leeds, our clinic spaces are used by quite a lot of different specialties, so you would have to take them up and down constantly, because you maybe don't want that in clinics where that isn't relevant and so on. But I think the important point that Raj is making, you need to have clinical teams that are engaged and that work with each other. So I think you need to have, as rheumatologists, the engagements from the IBD team that they want to work with you and ask the patients, and that they're willing to field initial questions, maybe do a very rough symptom assessment, and then decide who they refer on or not. And equally, on the receiving side from rheumatology, you need to have an understanding as gastroenterologists with them, what type of patients they can take, which pathway locally those patients should take, and what volume they can cope with. I think I want more gastroenterologists to ask this question, more IBD nurses to ask it, and then refer patients more appropriate. But what we can't cope with on the rheumatology side, for example, I would imagine if suddenly for a 3 months period, you ask every patient and then you refer every sixth patient. With the volume that we have in IBD clinics, we would easily kill all your new patient appointments for quite some time. So I think it's getting that balance right and getting an agreement how to do it. And for example, in Leeds, we operate a joint clinic between rheumatology and IBD, but we reserve that for cases where the diagnosis is firm in both areas, rather than sending patients who've got either an inflammatory bowel disease or inflammatory joint disease and have some other symptoms for investigation, because the capacity in that clinic isn't there to do it timely. And indeed, it would lead to unacceptable delays. So you need to figure out what your local best working arrangements are so you can get to timely diagnosis. And I personally think joint clinics work best when they take the very difficult cases rather than the simpler ones. It's an expensive way to run a service. It's a very good way to run it, but very expensive.
Fine. So, Christian, you've touched on joint clinics and how you use them, certainly. But the other thing is, do you have referral pathways? Let's say you pick up these patients. Are there processes in place?
So we've got a rather informal pathway, and it's probably informal because we run the joint clinic every couple of months and we know each other very well. So basically, both on the rheumatology side and the IBD side, we know who the people on the other side are. We've got good working relationships, and a lot of stuff is done informally by email or with referrals directly to the respective other clinic for investigation rather than on the joint pathway. And when you know each other very well, that works. If you don't know each other very well, I think you have to have this far more fixed. And if you start afresh, I think it's good to sit down and say, tell you what, this is what we can deal with. These are the patients we want to see. This is the investigations I expect you to do beforehand. And I think there's no one model that fits for every hospital. And indeed, there may be some hospitals where you don't actually have both services present. So you need to probably work with a neighboring trust and so on. So if there's one thing for the IBD colleagues out there, find out who your rheumatologists are locally and develop a way that works for both sides. And by talking to each other, actually already your knowledge will improve, your patients will be diagnosed quicker, and you probably will be better at liaising when it comes to difficult decisions.
I'm really interested in what you just said there, actually, Christian. So I was thinking as you were just both of you actually describing before your services, you both work in quite well-established centres, quite large centres. So actually for our colleagues listening in who maybe work in smaller centres, I guess what you've just described there, Christian, in that kind of, make a connection, have a conversation, even if it's not within your own individual sort of immediate organisation, those things could apply to a smaller centre. Just thinking, these patients will present everywhere, won't they? So how do we support colleagues working in smaller, less established centres to make sure we're making those connections really from the beginning?
That's a really important point, Lucy. And what we shouldn't say is you either have the gold star model or you don't have anything. I think there's so much that can be done with limited resources. You just need to find a willing counterpart on the other side, and then you can start small and develop things from there, and see also what the demand is. We shouldn't assume that the demand for, an MDT to run together or a joint clinic is there in every place. But yeah, getting the working relationships, getting to know each other. And I've learned so much from my colleagues that I think I've gotten a little bit better on who to refer and who not to refer over time. And that only comes from that interaction and from the feedback once you send a patient that actually, no, but you thought was inflammatory, doesn't sound inflammatory to us at all, and we're quite happy. And vice versa. Sometimes when you thought like this isn't inflammatory and you learn like actually there's rip-roaring inflammation, you could have sent that patient a bit earlier.
Definitely. I guess, Raj, from your perspective as well, from that, then the rheumatology perspective, even if you didn't have an Axial SpA full clinic or an Axial SpA lead, in fact, how would you recommend you rheumatology consultants consider that connectivity into gastro?
Yeah, no, thanks, Lucy. And I really want to pick up two very important points that Christian made. And one is that I think, as Christian says, it's really useful to have a lead person on each side. So even though there may be more people interested, have a gastroenterologist who's an IBD lead for referrals and discussions, and on the rheumatology side, have a rheumatology lead who's the lead for the discussion, so the discussions can happen and creating those pathways. But Christian touched on another point, which is really relevant for all of us running rheumatology services, and that is capacity. So we all have huge backlogs at the moment. Follow-ups, new patient appointments are challenging. And as Christian says, if we go and put a whole load of new things in that drives in a lot of new patients, that may cause problems. So, and I'm not saying it's the wrong thing, but I think walking into these things with your eyes open is crucial. Know your own rheumatology service well. How many new patients am I seeing? How many follow-ups am I seeing? If you can get someone to model, if I'm seeing 20 new back pain patients a month, what will that mean? I think is really important. And then bring that bit in. But I'm also a big fan of what Christian says, and I think this will come in terms of digital resources to help us really define who should come from primary care to secondary care or from secondary care services amongst each other, and can we use those digital resources to really fine-tune the patients we need to see?
We talked about doctors. Do other healthcare professionals in gastroenterology have a role here? Say the IBD nurses, for example. Can we use them?
Definitely. I think the IBD nurses come with one big advantage. I think they have a slightly more holistic approach than doctors. And they're also, if you say there's a checklist of tick boxes that you have to do, like for a biologic screen or something, nurses are fantastic at following that, whereas doctors are terrible at following it. What the doctors come in is, I think, our strength is making decisions when the situation is very shades of grey and not black and white, and taking risks in balancing things. But we're terrible at following checklists. At least that's my gastroenterology experience. I think the nurses are very good at that. The nurses are also good at getting patients feel comfortable enough to talk about things that maybe are not centered to their disease, but more on the periphery, because often they feel I shouldn't burden the doctor in a short appointment with all those things. So things that definitely come into play. What's a bit more challenging is they will have come from a general nursing background, went into gastroenterology, maybe as a ward nurse and endoscopy nurse, then trained in IBD. So their knowledge of things that are extraintestinal is a little bit less, because they don't come from quite the same broad physician training that a gastroenterologist will have come from. So I think we need to invest in training a little bit more about assessing skin, joint, and other things, because that will have not been a focus in their IBD nurse training.
The multidisciplinary thing is really interesting. Actually, we've done a previous one-off special episode with an ophthalmology colleague, and we had some of the very similar conversation. Actually, how do we get our wider MDT really working with us on these issues? So I guess one of the things that I'd be really interested in, Raj, is views from yourself about where could we point colleagues to, or how could we support colleagues in some of that education aspect of it? So recognising we can't just get it all straight into ask all these questions in clinic. You've mentioned a couple of those already, but I wonder if you give us a bit of a recap from your perspective on where gastroenterology colleagues could go to get help and practical tips and tools on these types of issues.
Yeah, thanks, Lucy. I think there are lots of resources out there now. And again, coming back to digital resources, that people can access things like podcasts and videos all over the place. I would point people to the NAS website again, the Acton Axial SpA website. There are lots of instructional videos and lots of videos that are shot by gastroenterologists, by rheumatologists, to help each other facilitate that pathway to reducing the delay to diagnosis. I think going to meetings can be very helpful. And I see these days lots of sort of cross-collaborative, cross-specialty meetings where you'll have a rheumatologist, gastroenterologist, dermatologist, ophthalmologist, perhaps in one meeting sharing best practice. And I think those are really good places to go along to and pick up the information. But it's keeping that information exchange going, and it's both sides. So rheumatologists learning gastroenterology, and gastroenterologists and nurse specialists learning rheumatology, but going to the websites, keeping the knowledge up will help people think about inflammatory back pain in their clinics.
Okay, so Raj, you've talked about NAS having great resources. You've mentioned the website as well. So Christian, can I ask you, is there anything in the gastroenterology arena, maybe the BSG site, that you would suggest?
There are some resources on the IBD site, but actually I think NAS has done a great job. So I think replicating those is not necessarily needed. I think what's probably important is, apart from all the online resources, to have some local training. And I think, for IBD teams to reach out to their rheumatologist and say, in our next CPD session, could you do 45 minutes on how to investigate joint symptoms for a gastroenterologist or for the IBD nurses? I think that would be quite useful, and vice versa. And actually, just by going into those meetings, you actually increase the amount of interaction between the departments, and each other a bit better. So I think use the available resources nationally, but do try and have something local every now and then. And if you can, have some case-based discussions, because they're actually fascinating and engaging. And when we run our educational meetings in Leeds, we do workshops, and it's just for IBD doctors and nurses, but we vary in who we do the workshop with, and every couple of years or so we get a rheumatologist involved and discuss cases. And it's over a case, I think you can learn a lot more than a didactic lecture.
Yeah, absolutely. It's that making it real thing, isn't it? And getting much more from that process. And what about then Christian, and then Raj, following on from Christian, any sort of useful pointers that from a clinical perspective you would recommend giving to patients? So for clinicians listening in, what would you encourage them to signpost patients to who may be starting to have some of those symptoms or expressing interest in trying to find out more?
So for IBD patients, there are really two different resources. One, there is the information provided by Crohn's Complaints UK, which is the patient charity for patients with IBD, and they've got a lot on extraintestinal manifestations, including joint problems. So I think that's a good place to go for a bit of wider background reading. And then I think the symptom checker is a great place to go to see whether you should ask for a referral via your IBD service or via the GP for patients. So I think the NAS symptom checker is a great place to go. And then I think once they have a diagnosis, I would obviously recommend the NAS materials. But it's quite important that people understand that when they have got problems, that they need to be investigated and get the right answer. But it doesn't necessarily mean you've got ankylosing spondylitis or you do have IBD if you have symptoms and you have the other condition or so on, but it needs to be looked at. And I think the symptom checker is probably the best place I would point people to if they got concerns.
Yeah, and I would agree with that. I think that the symptom checker is the place to start. And then, of course, once that's been completed, that can be taken to a variety of healthcare professionals. It could be GP, it could be a first contact practitioner, it could be a nurse specialist in the community who can then facilitate referrals, or it can even be the direct referral from gastroenterology through to rheumatology. So I think that's an excellent place. It's a simpler way to just start and get the ball rolling.
I'd like to thank both Raj and Christian. Really learned a lot today. Thank you very much for your valuable input and time today. Also, I'd like to thank our listeners for joining us. To summarize what I've understood in today's episode, we've talked about how patients with IBD can often have inflammatory back pain, and it's critical to identify this early and refer to rheumatology when appropriate. So basically, both conditions can be managed in a coordinated way to optimize patients' health. What I will reiterate what Raj mentioned earlier is please do visit www.actonaxialspa.com to find the NAS toolkit for healthcare professionals, to read the report into Axial, SpA and IBD in full, and find tools to use in your clinical practice.
Thanks so much, Christian and Raj, for joining us for a really insightful conversation. It's been great to hear from both of you, and really like some of those top tips you shared just around that. Have a conversation, make a relationship, and ask one or two simple questions. So thanks both so much for your time. And you can subscribe to Room for Improvement and keep an ear out for the launch of season 2, which is going to be featuring the NAS Aspiring to Excellence teams talking about driving improvements.
Please do follow us, as we will also have some more guest episodes through the year focusing on reducing the delay to diagnosis and the Act on Axial SpA campaign. Thank you again for joining us, and goodbye.
Room for Improvement is brought to you by the Aspiring to Excellence programme from NAS, which is sponsored by AbbVie, Biogen, Lilly, Novartis and UCB, and in partnership with SpA and the NHS Transformation Unit.